be here all day, so we'll answer questions. So don't feel like if you have a question and you missed it, just ask us later on in the talk. Again, I've got just work for every company and every drug company. So again, now that we actually have FDA approval for Lumason in the United States, we expect to have more use and more off-label use of these agents. And I really like this as an addition to our imaging toolbox. So as we don't not do CT and MR anymore, but there are certain situations that ultrasound contrast really improves patient care, and particularly patients that may be in renal failure that need a contrast study and some other things as we go along. You'll hear some other places where we think it really is helpful. So again, we add this as one thing and we pick the patients that are most appropriate. Let me just go over what are the advantages of ultrasound contrast. Number one, no renal or hepatic toxicity, so we can use these safely in patients with renal failure or renal obstruction. It's real-time assessment of vascularity, so we can visualize all phases of enhancement at very high frame rates versus the snapshots that we see in MR and CT, and it's the best temporal resolution in any cross-sectional imaging. We get a contrast-only image with excellent background subtraction, so we can see very small amounts of enhancement which may be volume averaged on CT and MR. We have a very narrow ultrasound beam which improves visualization of vascularity in small structures such as septa, mural nodules, and improves spatial resolution. There's no ionizing radiation, so we have an improved safety profile. These are true vascular agents, so we have no extravasation of contrast into the interstitium as CT and MR, which may lead to improved quantification when we're moving with quantification. I think Stephanie will talk about some of that in some of her talks. It's a very short half-life, which allows us to do multiple injections. So some machines, probably between 5 minutes, other machines maybe to 10 minutes, the agents will last. You can always give a second dose. And like I said, when we were doing dose ranging studies, we injected 45 times the dose, and no one had a problem. So although the package insert says you shouldn't do more than 2 injections, if the patient needs it, you should feel comfortable in doing as many injections as you need. It's portable, so you can perform these in the ER, ICU, or at the bedside. That's kind of a plus or minus depending on if you're the patient or the person having to go up and lug the machine. The availability to perform the exam without sedation. So in pediatrics, you usually sedate kids for CT and MR. With ultrasound, even if the kid's writhing around as you're doing the exam, you usually can get enough frames to get a good diagnosis. You can also have the mother hold the child as you're doing the examination in many different positions, which again I think is very helpful in terms of the children. No metal interference in terms of MR. Workflow, because you can see your results as you're doing this. You can decide if you need another dose or you need to do something different. Low cost and improved visualization of very small amounts of contrast. So in terms of things like radiofrequency ablation or cryo, where you're following these patients and you want to see very small amounts of vascularity if it's remaining, we do much better with ultrasound contrast. Again, they're better tolerated than CT and MR with fewer and less adverse events and not nephrotoxic. And again, we can use these to visualize the microcirculation and quantify perfusion using a bubble pre-perfusion and technique, and I think Stephanie will probably include some of that in some of her talks. Again, the disadvantages are you need to have an IV. So again, each of you is going to have to work out in your center what's going on. There are some bizarre laws at some states. So in Ohio, for some unknown reason, sonographers are not allowed to inject contrast. I think it's the same in New York. So it's really a regional thing as to how you're going to do this. You do need 2 people. You need the sonographer to be ready to scan as soon as the bubbles are injected. So you do need a second person to inject the bubbles. They don't necessarily have to stay in the room after they inject unless you need a second injection. You get a large amount of data, and there may be PACS issues, and we can talk about how we recommend collecting data. I think when you're starting out, you may want to save more information just so you have it until you feel comfortable. And as you gain more and more experience, you tend to save less and less information. And obviously, you need to buy the software for the machine to do these studies. We've already talked about the microbubbles, but just again to highlight, these are a gas that's not very soluble in blood, and we have a lipoprotein or lipid shell, so these are a little bit stable. They do funny things with ultrasound by resonating, and we can control what they do by the power output. They're smaller than red blood cells, and again, they don't leak out of the interstitium, and they're not trapped or excreted by the kidneys. Excuse me. I already talked about the contrast agents. These are the FDA guidelines for these. And again, I think the doses are probably too high now with modern equipment, so you need to adjust depending on the equipment you have. And as you get, the equipment vendors are getting better and better, we're using smaller and smaller doses. For pediatrics, the recommendation is to do a by weight dose. For adults, it's a standard dose. So to start, you're going to need to get your contrast-specific software. You're going to need to have your contrast agent. I think that some pharmacies will only allow you to have one agent in an institution. Many of your department or institutions, cardiology is already doing this. They may have one on the formulary. It's often Definity, because I think Definity was approved first, and I think it has a better distribution among cardiologists. So you need to go to your pharmacy committee and decide which agents you want. In the past, we were getting reimbursed for Bracco only, so we told people that they can bring that to their pharmacy committee to make sure that they get Lumason. Now with the new CPT code, which is agnostic, there may be less of an influence as to which agent you're going to use. Again, figure out how you're going to do IV access and have two hands available. And again, that software is very specific. Each vendor has their own recipe. It's getting to the point, it's like MR. So we've got all these different ultrasound sequences. In general, you can't choose which one you're going to use. Each vendor has a button, maybe two buttons that you can use. It's optimized. You don't have to worry about all the physics. All that is done. And again, you may hear words like pulse inversion, harmonic imaging, power modulation, and combinations of the both of these. But again, you don't need to understand that it works. And again, this is the simple one. We talked about this in the first talk. We insonate with a 0-degree pulse and a 180-degree pulse. That allows us to subtract those together to get a B-mode image. It allows us to add them together to eliminate background tissue, and it allows us to add them together to get a contrast-only image. And now we can display both a real-time B-mode image that does not have as high a quality because we don't have Sono-CT. We don't have a lot of the other features on because we can't do that while we're doing contrast. And it's kind of a synthesized image, and it's really not there for you to make a diagnosis. It's there for you to know where you're scanning and to make sure you stay on the lesion. And then you have your contrast-only image. We've already talked about IV access. Again, 20-gauge needle is preferred in pediatrics. If you want to use a smaller needle, that's fine, but adjust how you're pressing. You don't want to inject quite as fast because you're going to increase the pressure and bust the bubbles. So do you need informed consent? So I would say when we started 20 years ago doing this, we did get written informed consent, and obviously anytime we were doing research, we got written informed consent. Then when these agents were approved for use in cardiology, we just went to a verbal informed consent. And now that we do have an approval for abdomen, we don't actually get a written informed consent. We use the same informed consent that we use for CT and MR. And that's a general rule. You should consider it to be the same. When we do off-label use, we usually do tell the patient, we're giving you the same dose, we're using the same probe, we're just putting the probe over a different place and looking there. And again, only oral informed consent, not written informed consent. So again, in terms of performing the examination, you're always going to do your unenhanced exam first. And the key feature here when you do this is you want to find the plane when you're imaging that the lesion stays in the field of view as the patient's breathing. Because we're going to scan for minutes, you're not going to have the patient hold their breath. So what you want to do is roll the patient, try different windows, but find where, as the patient's doing normal breathing, the lesion stays in the field of view, so you can follow that real-time enhancement throughout all the phases of enhancement. So usually that means you're going to be doing longitudinal imaging so that the lesion will be moving up and down in the image but not in and out of the plane of the image. You're going to activate the drug. The drug will stay, can be used for several hours after you activated it, but always make sure that you shake it enough that it's resuspended before you use it. You're going to use that contrast-specific software. Each vendor has their own MI, that's the magic number. It's always less than 0.4. It's usually much less than 0.4. And then you're going to inject the drug, and then you're going to follow that with saline to make sure that it gets in. Like I said, I like to use 10 cc's of flush. Some vendors recommend 5, but I think giving the 10 helps push it in and gets a nice tighter bolus, which is very helpful. If you look at the cardiology, they tend to inject things much slower. The reason is they're looking at this big sac, the heart, and when they fill this up with a lot of bubbles, they get a lot of shadowing. So they don't want a high concentration of bubbles to avoid the shadowing. For us, we want that high concentration to get a really good arterial phase image. So we're going to inject faster than they are in cardiology. So don't look at cardiology papers and inject very slow if we're doing abdomen. We're going to start the timer, and the rule is you start the timer when you inject the saline. And this is very helpful when you save images, that you know exactly where during that process you've taken those images, and then you're going to save clips or images. We can discuss how you do that. I think the LIRADS for liver has a very nice application of how to use for liver. For kidneys, we don't need to scan quite as long, and usually we save a video clip but then go back and crop it and only send select small videos or images to the PACS system. Again, we talked about this system. It's quite useful. We've already talked about how to activate the 2 drugs. Optisone is very similar. You put in the saline and shake the vial. In terms of dosing, again, you're going to have to kind of titrate your dosing to your equipment, and as the equipment is getting better, we're using smaller doses. If you do inject too much contrast, you'll actually get shadowing from the bubbles. So as the bubble concentration decreases, the shadowing will go away, but then you've now missed the arterial phase. So that's usually very important information. So if that does happen, you may want to give a second injection, half the dose, to make sure you get a good arterial phase. And again, the package recommended doses, I think, for the vast majority of machines now are quite high, and you probably should start at half that dose. And in terms of how much can be administered, again, package dose usually says 2 doses, but you should feel safe if you really need, from a clinical standpoint, to do more. So when we do RFAs, and we do multiple injections to make sure at the time we're doing the RFA that we've got the tumor, we don't care that we use 2 vials if we have to. And again, all these drug companies have tested this at 20 or 30 times the doses you're giving and never had any adverse events.
Can I ask,
Yep.
have you noticed if patient weight has any determination on how much is the dose?
Yes and no. So in general, if they have a lot of fat, their vascular volume may not be bigger, right? So we usually just use the same dose on everyone. Sometimes if you have a larger patient, you may have penetration problems, and in that case you may want to give more to just get more bubbles in to get better imaging. But in general, we always start with 1 dose regardless of the patient body habitus. Peds, again, depends on the weight of the kid and the doses adjusted. But I think after about 120 pounds, the dose is now the same as an adult. It's not a kit. But I think that's where, if you calculate out per gram, that they would use the standard dose. So most teenagers, you're going to use a standard dose. You're not going to go by weight.
Minimum dose that we should start at? Is there a...
Let's go back. Since I don't do peds, I don't have this memorized. So it's 0.03 milliliters per kilogram. That should be the minimum. You may actually even go smaller, depending, again, this dose may be too high, but that's a good starting place. So scanning parameters, there are several options of things you can change. We recommend that you just use the defaults. They're perfect. The only thing you really need to change is the gain setting. Yes?
Do you have a specific dosage for the pregnant ladies?
Same as an adult.
Same adult. How safe it is for the pregnant ladies?
So it's never been studied. It should not cross the placenta, and there are people that have dose. So we would only do this if the referring doctor gave us a note that says, this is the only test, we have to have this, we have no other option. But my understanding is of all the female patients that are pregnant that they've dosed, there's not been any complications.
Okay.
And the same thing with breastfeeding, should not interfere with breastfeeding. But again, no studies.
Okay, sweet, thanks.
So you can adjust the MI. I recommend you don't do that, because if you increase the MI, you're going to bust the bubbles. Usually what the vendor has is probably optimal. You can turn up the gain, or you can decrease the gain. And when you're starting, you want to adjust the gain on the contrast image so that you have very little signal. So you'll see the echogenic reflectors. So you'll see some proximal fat. You may see the diaphragm, but you don't want any signal in the liver or the kidney, whatever you're looking at, and that's the proper place to set the gain setting. If you try to eliminate those secular reflectors and you turn the gain down low, you won't have any imaging after you inject the bubbles. If you have some signal in the liver, you're going to have a veil of noise on the image as you do things. So again, looking at the image when you start on the contrast and just dialing down the gain so you'll see the secular reflectors, nothing in the soft tissue organs is ideal. All the vendors will allow you also to adjust the gain on the B mode separately. And depending on which vendor it is, you go to there and you can adjust that as much as you want. It's not going to affect your contrast image, but you can adjust that so you can see the B mode image and see your lesion better. We really recommend you use the dual display so that you're going to get your real-time B mode image and your contrast image, so at least you know you're staying on the lesion and you're in the right place. Most vendors now will also allow you to copy the measurement. So you can put cursors on the lesion on the B mode image or the contrast image and transpose that to the other image so you know exactly if it's the same lesion that you're looking at. And I think that's, again, very helpful. Sometimes you may not see a lesion on B mode imaging, you only see it on contrast. So it allows you then to go and plot that on your B mode image. So if you want, you can go back out of the system, do your standard B mode image, and optimize it to see if you can find the lesion. Again, you're going to do your standard examination first. And again, the key here is find the lesion, find the patient position, transducer position, that the lesion stays in plane as the patient's breathing. I don't like to have patients take deep breaths in and blow them out, because then things are moving up and down like crazy. It's better if you can find a nice position where they breathe normally and you have the lesion in there. Obviously, there are some things like the dome of the diaphragm that's impossible for you to do. So you have to do the best you can. And sometimes what you'll end up doing is, as the patient's breathing, you'll see it when they inhale and lose it when they exhale. It's not optimal, but you can still get good information with that. But again, controlling their breathing so at least you get a continuous flow of images so that you know where you're at is very helpful. If you want to give a second dose, like I said, that's fine. And it could be that you had a suboptimal first dose, you have more than one lesion, you weren't happy with your first injection, that's fine. Depending on the situation, if you really want to look at another good arterial phase, you may want to bust all the bubbles so you don't have any bubbles left. So what we recommend is you get out of contrast, go into color Doppler or high MI technique, open up the field of view and scan over the aorta or the heart, which will bust bubbles at a much higher rate. We have a button that's called Flash, which will do high MI, but only for a few frames. So that's not very helpful in eliminating a lot of bubbles. It's only useful for eliminating bubbles in a small area of the frame to do some specific things that we'll talk about as we go through today. And then again, you can do multiple injections, and I think it's safe to say you can do as many as you want, depending on the clinical situation. As long as it's clinically indicated, I think it's safe for you to go ahead and do that. Saving images, again, I think when you're starting, you want to save more images and cine clips so you can go back and review and learn and feel comfortable. Obviously, if you saved a 5-minute clip, it's gigabytes. You can't send it to your packs. You're busting bubbles as you're scanning so that you're going to not have as much time. So we really want you to get to the point where you're doing intermittent scanning. Obviously, as we go through the day and we talk about how to characterize lesions, particularly in the liver, the arterial phase is very critical. And things are changing very rapidly. Within seconds, things are changing dramatically. So you want to collect all that information in a cine loop so you can go back and look at it. But once we get to the portal venous, late portal venous phase, delayed phase, when we're looking for washout, that happens very slowly. It happens over tens of seconds or minutes, so we don't have to be scanning in real time. We can do short clips and then not scan, so we save bubble life, and then do this intermittent scanning, and I'm sure Stephanie will talk about that a lot, and there's a very nice, especially for liver in the LIRADs, that's a very good protocol to use. But again, you may want to collect a little more when you're starting. I think that's kind of normal. You have to remember that most PAC systems will not allow you to send huge clips. One thing you can do, there are USB ports on all these machines. You can buy a 4 terabyte drive, hook it into the USB port, and you can send all of those images and store them there. Obviously, if you store them on your hard drive fills up very fast, and you're going to have problems. But storing them, particularly if you're doing research or you want to review cases later, it's real nice to save them off to this USB, because then you can re-import them and look at them again. So again, let's just briefly go over how we do our exam. Standard B mode image, find the area of concern, identify the best location for the lesion. Another thing that I didn't mention is you want to try to get the lesion as close to the transducer as possible. Why? We're using very low MI, so we often have difficulty in depth. I think now we can get to 8, maybe 10 centimeters. In the past, it was maybe only 6 centimeters. But if you have a very deep lesion, you're going to have a hard time scanning. So if you can roll the patient and get the lesion closer to the transducer, you're going to have better luck in getting good images. You're going to start the IV. You can do this before the patient comes in the room. We usually do it after we do our standard exam. Doesn't matter. We reposition the patient, identify the area of interest, activate the contrast agent, inject the contrast agent, followed by the flush. When we start the flush, we say time on. So we have these two people, and we coordinate this. So the sonographer is watching the machine. The person injecting is telling her, contrast is in, saline is started. So when she says saline is started, the sonographer knows to hit the timer button. So there needs to be some coordination between those two patients. You're going to continue scanning and recording based on the application of protocol. Another interesting thing that I'm sure Stephanie is going to go over a lot on the liver is if we're looking at metastases, the key thing for our metastases is black holes, washout. So after you looked at your target lesion, usually that's done within a minute. You still have a lot of bubbles. You can sweep the whole liver and look for other black holes that may be additional metastases. And I'm sure Stephanie will go over that in more detail as we go. review the case if you need to do a second injection, and then follow us again as we do that again, and then send your images and clips to the PACS. So in our practice, who are patients that are appropriate for CEUS? Renally impaired patients requiring a contrast study. Unfortunately, I think we have a problem with the oncologists in that the U.S. standards of how to work up patients in their normal protocol, CEUS doesn't appear. So our oncologists feel somewhat uncomfortable to use ultrasound contrast as a primary tool because it's not in their normal flow and protocols, and therefore they feel they may be at risk for medical legal implications if they don't do something. So usually we get the patients that MR, CT have failed, or they don't get an answer, or conflicting, or they can't get a contrast study. Obviously patients that can't get contrast in CT and MR and CT do not answer the question or have conflicting results, when it's important to know that no enhancement is present. So again, part of this is renal, indeterminate renal masses, post-RFA or post other procedures, to decrease the radiation dose, particularly in pediatrics, when you need a portable exam, and to decrease the amount of sedation in pediatric patients. We're going to go over organs in detail. I'm just going to briefly go over to set the stage. We'll go over these in much greater detail. But in terms of liver, contrast washout is indicative of a malignant lesion. Globular peripheral enhancement is diagnostic of a hemangioma, as it is in CT and MR. FNH has spoke wheel arterial rapid intense filling and becomes iso-intense. So here's my little graph of how we interpret. Everything above the line is benign. And we use the arterial phase for liver imaging to characterize these benign lesions. Hemangioma, globular peripheral enhancement with central pedal filling in. FNH, flow beginning centrally and going out with a spoke wheel appearance. Adenomas, enhancement coming from the outside in. Adenomas, about half of them can show mild washout. And again, I think Stephanie will probably go over that in much greater detail. Below this, you can see our malignant lesions, and the key thing here is washout. And we can use the timing of the washout to help characterize lesions. The vascular phase is somewhat important, but remember we have hypovascular mets, we got hypervascular mets, we got ring-enhancing mets. So the arterial phase is relatively non-specific, and it's the washout that's really characteristic for that. Here's an FNH, and again you can see the gorgeous spoke wheel appearance, the marked arterial hyperenhancement. Another thing you should realize is we've got such high temporal resolution that I'm going to stop this clip if I can, and I can pull this back, and I can go back, and I can now see that the blood flow is really starting in the center and going out, and I can pick some frames that have a nice spoke wheel appearance. Helpful in flash hemangiomas where poof, it's there. You can go back and see, and you can usually see that they have globular peripheral enhancement. Again, here's just showing in metastases washout. Here we've got a ring enhancement, and as we go through time, you'll see that these end up having washout. The areas that are hyper-enhancing in the arterial phase wash out. Pediatrics, there's not a lot of literature yet. There's a lot of literature on VCU, but not so much on livers. This is one study that I found from Europe that they looked at focal liver lesions and showed really good ability to characterize those lesions. Renal, a little bit different than liver. Liver, we've got a lot of rules and complications. Kidneys are kind of easy. If it's got flow in it, it's probably bad. If there's no flow in it, it's probably good. Minor a few exceptions, and we'll talk about this at length, and we find that we can characterize indeterminate renal masses with very, very high accuracy, significantly better than CT and MR, particularly in papillary renal cell carcinomas that often are misinterpreted as complicated cystic lesions on CT and MR. And again, here's a similar flow chart, but again, the bottom line is if there's no flow, it's benign. We presented our first 1,000 lesions several years ago in radiology. This was our enhancement patterns that we use, and again, I'll go over this in more detail in our renal talk. But the bottom line is, if there's no flow, you have 100% negative predictive value that the lesion is benign, and we followed all those patients for 10 years and they never turned into anything. So we feel very confident that if you do an exam, you don't see an enhancement in the lesion, regardless of its Bosniak classification, that the lesion is benign. There are many other applications. We may not talk about all of these today, but we're open to answer any questions you have on them as we go through the talk. Endoleaks is very helpful. Inflammatory bowel disease, I'm sure Stephanie is going to give a talk on how useful this is to eliminate all the radiation, because these patients tend to have multiple examinations in the course of a year. Pancreas, prostate, interventional, big applications in interventional. You can inject this through tubes. Some people are having people drink this, so you can inject it or shove it anywhere you want, and using it. Very helpful in looking at abscesses. Again, a lot of these patients are in the intensive care unit that you need to find something. Tell if a tube is open, very easy for you to go up and do this in the intensive care unit as opposed to bringing the patient down to CT. And carotids, which we're not going to talk about today. I'm assuming that tomorrow in the cardiology session there'll be a large amount of that. I looked at the level of evidence for different things. This is my interpretation. I'm hoping that the SRU agrees with me when we publish our SRU guidelines for use of ultrasound contrast in North America later this year. But I think for liver characterization, we've got plenty of evidence this works very well. We don't have as many for detection. It works, but we don't know really how good it is because there's just not enough papers out yet. Guidance for ablative procedures, excellent. Kidneys, characterization of renal masses, excellent. Guidance for procedures in kidney, excellent. Pancreas, somewhat in the middle, lower evidence. Spleen, lower evidence, just not enough literature. Small bowel, I think we're getting to the point where several people have been able to reproduce what Stephanie has done, and that this is very useful. Scrotum, there was some work on that, but not enough literature, I think, that we can say with definity, with complete, absolute definity that we can use this for torsion. There's a lot of work in animals, but not a lot of work in humans. Ovarian masses, work being done, but not a lot in the literature. Breast, again, I don't know that it's of much value. Thyroid, actually, we've just started using it in thyroid. And what we are doing is we get sent a lot of colloid cysts to aspirate. We aspirate them and we get no cells, surprise. So they get sent back to us to aspirate. So there's never going to be cells no matter how many times we stick them. So we've now done, if we get no cells on the first aspiration, the patient comes back and gets an ultrasound with contrast. And if there's no flow, we say it's benign, don't send the patient back to us. If there's flow, we repeat the biopsy in the area of the flow. And the first patient we did was stuck twice by my partners and got no cells. When she came back and we did an ultrasound with contrast, there was a focal area of hypervascularity. I biopsied that and it turned out it was a follicular cancer. So I think this is going to be a very useful way of guiding procedures for thyroid. Vascular for endoleaks works really, really well. And prostate, it works, but not that great. And we're now not using contrast so much for MR because we know it doesn't work. So it's unlikely that ultrasound contrast is going to do that. But just show, here's an endoleak. This is a patient that I did an RFA on, and we were actually scanning follow-up for that. But the patient did have an endoleak. They were following him with CTs without contrast. My sonographer always looks everywhere, as she should, and here we have a 1 centimeter gap in the stent, and there's huge amounts of contrast going in this aneurysm that was missed for years because they weren't doing a contrast study. He actually went to an ivory tower north of us and had an angiogram. They insisted this was a type 2 leak, glued him, it never went away, did him again, put him in renal failure, and now he's on dialysis. So we really have the highest temporal resolution and spatial resolution, and we can cine back and we can see where the contrast is coming from. No other modality would let us do that. In terms of cost, there's a study here from Europe that shows that ultrasound contrast is significantly saving, and I think that there are several papers now In Europe, what they like to do is they do the ultrasound. If they see a mass, they just dose them. A little bit harder for us because we don't have an order to do that. But what they found was in 85% of the cases, the ultrasound contrast answered the question and the patient did not need any additional imaging. So a very huge cost savings in the system. Urinary reflux, I don't think Stephanie and I do this, but it works very, very well, and obviously we're eliminating a lot of radiation. I think it's going to be the standard. It's presently the standard in Europe, and I think my understanding from talking to pediatric people that almost all centers are moving to using this instead of the radiation technique. So again, when do we use this? Patients with renal impairment, CT and contrast allergies, CT and MR don't answer the question, or when it's important to know there's no flow, are kind of our big applications. I would add our urologists don't believe CT and MR anymore, so our vast majority of our cases are kidneys because there have been so many misinterpretations of lesions, particularly papillary cancers in renal cells, that they really believe us much more than CT. There are guidelines, and I recommend you look at these. They can go over in a lot of detail and things we're not going to talk about, particularly the WFM guidelines. The WFM liver guidelines are being updated in a month. They should be out by the end of the year. And like I said, we're working on SRU guidelines that should also be out by the end of the year. But these have a lot more information than we can provide you in a one-day course, particularly about different organs that we may not talk about today. It'll at least give you an idea of what's being done and where you can use this. Obviously, we highly recommend you get training. That's why you're here. ICUS has done a wonderful job in trying to educate people. One thing I think that's very important, it's very helpful if you can go to a center that's doing these and watching a couple cases get done. I think it really builds your confidence that you can see how the exam is done, how to mix the drug, how to inject, etc. So I think that's something that's very helpful. And obviously, unfortunately, we can't dose patients here outside of a hospital. But again, I think there are several institutions in the U.S. that you can go and spend a day and watch how we do contrast and learn. And again, I think it just builds a lot of confidence that you see it's really not magic, that it works, it's very easy to do, and it builds that confidence that you're not scared when you do your first case. Again, you probably want to talk to your referring doctors. Again, our urologists and nephrologists know about us because they refer the vast majority of patients. All our oncologists know about us also, but again, they're somewhat reluctant to send patients to us unless it's a problem case. I think since we've been doing this for 20 years and have had great success, almost everyone in our geographic area knows we do this and we get patients sent. And actually, it's quite amazing how many people that have a problem look in the internet and find centers, and they come from all over the place to get an ultrasound contrast, which is kind of ridiculous for someone to fly across the country to get an exam. So hopefully more and more centers will do this so people have access to this technology. Again, only contraindication is hypersensitivity of the agent or any of its active ingredients. Excuse me. Again, most adverse events are mild and transient and resolve spontaneously. Most common headache, 1%, nausea, 0.5%. Back pain is probably about 0.5%. Adverse event has been reported in 0.13%, with serious adverse events in 0.0086. These typically occur within 30 minutes. Actually, they usually occur immediately after you do the injection. Most of the severe reactions are in patients with unstable cardiopulmonary conditions, and obviously you need to be prepared to have a serious reaction in your center. These are the CPT codes that came out now in January of this year, 76978. Targeted dynamic microbubbles, contrast characterization, non-cardiac, initial lesion, RVU quite good, 1.62. The contrast agent and organ are agnostic, meaning you can do any organ and you can use any of the agents, and you can bill for the non-contrast exam with existing CPT codes. However, what we're finding is that if you're doing this and the patient's already had a without contrast within a certain period of time, insurance companies are not letting you bill again for a second ultrasound without contrast. And most of them require you to put a modifier to tell them that the patient's not had a prior examination. So it's a little tricky. We found that out after we started billing. 76979, each subsequent injection if evaluating multiple lesions, maximum of 3. So again, you can do multiple injections for one lesion, you only can bill once. If you have multiple lesions, you can bill for the injections for each of the lesions. Yes?
Thank you. Please explain the difference between getting reimbursed with a CPT code from CMS versus the companies being able to advertise it because there is no FDA approval.
Sure.
And
so
people think if it's not FDA approved, you can't use it.
No. So the FDA and billing have no relationship to each other at all. And I'm sure that a lot of your billing that you're doing now is not FDA approved. There are very few MR contrast agents that are approved for everything. So the FDA approves these agents. Once an agent is approved for one application, that's telling you the agent is safe. So then you can do it off-label for many other applications as long as you're doing it in a way that there's literature that supports the use of using it. And that's why I say look at the WFM guidelines. It tells you what's appropriate to use for ultrasound contrast. Billing, on the other hand, has nothing to do with FDA approval. It is allowing you to bill based on what the AMA has decided is something that could be billed. So there's no reason why you can't bill for something that's not FDA approved if there's a CPT code. So all these off-label uses we can bill for, and I haven't done any really crazy stuff, but other people have billed for thyroid using this abdominal code and gotten paid. So our understanding is that you can use it for any organ. For sure you can use it for any agent. Just because the code is there doesn't mean the insurance companies will reimburse it. So again, it's approved by the AMA. We have the code, we have the RVUs. The problem then is insurance company may still say it's experimental, we're not going to pay. So that varies by region, it varies by insurance company. You know, you can battle the insurance companies. I think that maybe something, if we see a really big problem, that's something ICUS may help with in terms of contacting insurance companies, educating them of why this is very cost effective. So we're just going to have to wait and see how it flows. And it's not uncommon when we get a new CPT code that some insurance companies say no until maybe a year or two before they fall in line. So just to summarize, contrast increases sensitivity and specificity over non-contrast exam, similar specificities as CT and MR, less expensive, and then we're going to talk about these other things. But it's a very safe exam, and we have real-time ultrasound, and we have very slice thicknesses and background subtraction that are really big advantages. Yes?
I just have a question about the billing. Is a referral the only thing that the insurances are requiring, or do you need more?
So again, that's going to depend on your region. For us, ultrasound examinations do not need to be pre-certified, but my understanding is there may be some locations in the U.S. that do require it. For us, we don't have to have pre-certification. We just need a script from a physician. Oh, already?